The Thousand Faces of Virtual Reality. This course is brought to you by Gilad James Mystery School. Learn more at giladjames.com. Introduction. Recent studies reveal psychotherapy is effective in reducing gambling behaviors. However, an important issue in treating pathological gambling is that, despite understanding the negative consequences of continued gambling, problem gamblers at times experience an overwhelming craving to gamble. Furthermore, the therapeutic work carried out when patients are emotionally distant from the gambling situation, such as in a therapist's office, is hard to transfer to real-life tempting situations. Previous researches have studied the efficacy of imaginal and in vivo exposure to gambling-related cues in order to reduce gamblers' cravings either in cue exposure therapy or as part of a broader cognitive behavior therapy, CBT, package where skills are developed or strengthened while confronted to the addictive stimuli. In imaginal exposure, patients are asked to imagine different stimuli, while in vivo exposure requires the physical presentation of the stimuli. Results from these studies indicate that these two forms of exposure therapy can help reduce cravings among pathological gamblers and generate broader therapeutic impacts such as significant improvements on other gambling variables and psychopathological symptoms. Since the 90s, a new kind of exposure tool has appeared in clinical psychology, virtual reality, VR, or in virtual exposure. VR can be defined as an application that makes it possible for the user to navigate and to interact in real time with an environment in 3 dimensions generated by a computer. In virtual exposure is usually conducted using a head-mounted display, HMD or helmet, which is a pair of goggles allowing the presentation of images in stereoscopy, combined with audio stimuli and a motion tracker that follows the user's head movements. Both for cue exposure and broader CBT package, VR presents the same advantages as imaginal exposure since it offers great control over different stimuli and the rhythm of exposure in a context that assures patients' confidentiality and eliminates many ethical problems unlike in vivo exposure. However, VR also presents some advantages over imaginal exposure because it reduces problems related to lack of memory, difficulties inducing emotions solely with thoughts or patients' refusal to fully access their memories. Finally, VR allows therapists to control the impact of stimuli related to patients' other addictions on the course of therapy. For example, alcohol, cigarettes or drugs could also be found in a virtual environment to provide specific cues for a patient. VR also offers the possibility to conduct exposure and relapse prevention in various locations, for example, a bar or casino, that could provoke different reactions in the same person. The fact that VR is interactive and very similar to real-life situations could also positively influence gamblers' perceptions about therapy and encourage them to seek treatment. But the key argument in favor of using VR is its potential to replicate an environment where addictive behavior is usually taking place, thereby allowing to witness pathological gamblers' emotions and dysfunctional behaviors, and accessing their mental state as it is operating in gambling situations. Replicating gambling situations with a naturalistic setting in the safety of the therapist's office should be quite an advantage to treatment efficacy. A significant number of outcome studies have been conducted where CBT is combined with VR to treat anxiety disorders. Indeed, VR exposure has shown its efficacy in the treatment of acrophobia, claustrophobia, arachnophobia, fear of driving, fear of flying, social anxiety disorder, fear of speaking in public, and post-traumatic stress disorder. Less work has been done with addictions, but researchers have shown that VR can be used with pathological gamblers, either for experimental research, to induce cravings or in single-case trials. In 2008, a study using VR by Young and colleagues revealed that for pathological gamblers, the desire to gamble was influenced by wins, losses and the different amounts won, which was not the case for non-gamblers. This research is interesting because it shows VR can induce a desire to gamble, but it didn't use VR as a treatment tool. The first study using VR in a CBT program for pathological gambling was realized in Spain. Unfortunately, results from this research were never officially published. In the current lecture, 2 virtual environments and their clinical applications for pathological gambling and co-occurring problems will be detailed. First, data from a validation study and a pilot clinical trial with gamblers will be presented. Then, a presentation of a CBT manual for using VR will follow. The 2 virtual environments described in this lecture, a bar and a casino, were the first in North America designed for the treatment of pathological gambling to be empirically tested. Note that the choice of video lottery terminals, VLT, in bars and slot machines in casinos was based on epidemiological data on gamblers' playing habits. Before using these two environments in treatment, see section 2.1.2 for a detailed description. A validation study was conducted in order to determine if they could induce a desire to gamble. First, a training immersion in VR was performed to allow participants learning how to navigate in VR and manipulate the equipment. All immersions were performed on a PC computer with an InVisor SX HMD, a pair of computer loudspeakers, an InterSense Cube 2 motion tracker for measuring head rotations, a wireless mouse for translations, navigation in the virtual environments, and a box with push buttons allowing the user to physically interface and play with the VLT and slot machines. Second, participants removed the HMD and had to physically play a game of Scrabble TM, a control condition where the game is not significantly based on chance, with the experimenter for a period of 7 minutes. Then, participants were randomly assigned to 7 minutes of playing on a real VLT, gold standard control condition, playing VLT in a virtual bar, VR bar condition, and playing slot machines in a virtual casino, VR casino condition. Subjects' desire to gamble was assessed after each game with a gambling craving scale, GACS, and physiological reactions, skin conductance and heart rate, were measured throughout the experiment. It is noteworthy that participants recruited for this validation study, N equals 67, had prior experience with games of chance and VLTs but were not pathological gamblers. Participants presenting a potential gambling problem according to the South Oaks Gambling Screen, SOGS, were excluded from the project and referred to proper resources. Accepted participants were divided in two categories according to self-reported frequency of gambling: frequent gamblers, played at least once a month with VLT or slot machines, or non-gamblers, played a maximum of twice a year. Results show that physiological arousal, according to the skin conductance, desire to gamble, and anticipation of positive mood while gambling were statistically higher in the frequent gamblers group than in the non-gamblers group for the real VLT and the two virtual environments. The time by condition interaction was significant and revealed that, compared to playing Scrabble TM, the craving to gamble was increased as significantly in the two virtual conditions than with the real VLT for the gamblers group. In sum, the two virtual environments seem to provoke among gamblers the same desire to gamble than a real machine, even if no real money was involved. A pilot clinical trial was then conducted with 28 pathological gamblers participating in a 28-day residential CBT program with group and individual interventions. A more affordable HMD was used and the treatment was adapted from an already validated CBT program developed by Ladasor. Only 2 sessions of the CBT program were modified to include VR, the first and last sessions described further in this lecture, allowing to compare the use of imaginal exposure, standard technique, with immersions in virtual reality in the bar. Participants were randomly assigned either to the virtual reality condition or the imaginal exposure condition. Results revealed that the first VR immersion allowed finding significantly more high-risk situations and more dysfunctional thoughts than the standard imaginal exposure exercise. In the second experimental therapy session, devoted to relapse prevention, immersion in the virtual bar was associated with stronger changes in urges to gamble compared with the imaginal exposure condition. Furthermore, a multiple regression predicting pre- to post-treatment improvements revealed that the strength of changes in urges to gamble induced during the relapse prevention session significantly predicted patients' improvements. Finally, another interesting finding from this clinical trial is that no ethical issue or adverse events were reported following the use of VR, for example, inducing cravings that would be too intense.